biomarkers in mild TBI. Actually, it's specifically mild TBI, because 1974 itself, we have learned what is a Glasgow-Coma scale. The Glasgow-Coma scale of EVM and the evidence and what is the severity, what is the mechanism is well understood, and it is from 1974 itself. But the issue is that if it is a mild, how to identify? For example, people comes with a mild injury, they were spot just very short span of time were unconscious and it became normal, and it doesn't show outside. So the clinically is not evident. Clinically, we are not able to look at it. So at this time, how to prognosticate? Even if it is severity, they may not accept. And the cost is an issue. And some people may not accept to go undergo for CT scan, MRI. And we all know it's a severe brain injury or traumatic brain guidelines. And if it is a moderate also, if the GCS is low, fine. If the GCS is above 13, and we are not really having a proper assessment of cognitive function of the brain of pre-op, like for example, arrest before and arrest after, the injury before, injury after. Another important point is that the delay and duration. When was it? Because the astrocytes, glial cells, neurons, axons, when they get damaged, that is going to take a long time to get its own secondary effects. For that reason, to assess, for example, if you go for CT scan, if you go for MRI, you can look at the different structural or the hypoxic damage, anything you can be identified, but it is not seen because it takes time. So how do you catch early? What are the problems are facing when you are doing the procedures? Like for example, some centers have a very nearby ER CT scan. Some centers are very big hospitals, will be long time. So there's the issue of transportation. There's the issue of cooperation, because patient may be irritable, patient may doesn't want. And some people doesn't want to take because of radiation. And if you want to really study, and the contrast-induced nephropathy we all know as intensivist, and sometimes very difficult to understand diffuse axonal injury. Neurologist and neurosurgeons comes and says, boss, we are fine. From our side, nothing is there. Brain is normal, because they don't need surgery. It doesn't mean that doesn't need surgery, doesn't mean that he is not severe. He is not sick. It is requiring that he may not require surgery because there is no anatomical or bleeding is there. But the diffuse axonal injury outcomes are not so good. Depends on, again, the prevention of the secondary damage. With that, the prognostication becomes difficult because there is no evidence. Presently, we all have to have practice, evidence-based practice, and attendance is not going to just blindly believe. So we need to have an evidence. And sometimes in arterial dissections and vascular insufficiency influx, you need higher end education studies, which is more invasive and as well as most costly. And looking at the hypoxic injury identification, it's not easy. We all know, because of brain death management we manage now, and very difficult to put the patient into the console with the implants, metallic implants. And again, you look at the DI of how much is the averaging of the image averaging is there. Particularly when it comes to this patients in MRI, some people are very claustrophobic. They cannot get, and the duration and time and easiness to do, manpower requirement, all these things are problems. So for this biomarkers are going to be useful in particularly mild TBI. What is a biomarker? It is actually biological based parameter. It's a biological based parameter and objectively measured. Okay, it is objectively measured and it is evaluated indicator of a normal pathological process or physiological process, or it is a treatment for the pharmacology. Next slide, sir. So what is a pathophysiology? As I told you, when suddenly the primary injury occurs, there is a cellular damage, there is a degeneration of the cells which can get inflammation, and there is a protease activation and oxidative stress, and which can go into the apoptosis or necrosis with the metabolic changes, and there is a disruption of the blood-brain barrier which can cause the further delay and further outcomes. The prognostication is important in this, because like concussion injuries, where you will not see any injury outside, but the damage is very heavy, like diffuse axonal injury in the brain, and it is going to take a long time, and in the primary it doesn't show outside. So the secondary degeneration may continue for weeks to months. That is the reason we should be able to identify early. And it is because all these cells containing protein, it will be shedding into the serum and CSF. If the blood-brain barrier is normal, it doesn't come into the serum. If the blood-brain barrier is abnormal, it enters into the serum as well. So that is why the specific protein markers or the expression of the protein and the cleavage of the proteins where they have. So these kind of proteins can be assessed, understood, and they've studied, saying how benefit it is. Next. So normally whenever we do, it should be cost effective and it should be rapid, it should be non-invasive. That's where anybody wants. If you want to do any test, we want to know what we are doing in future with that. We cannot just do the test because maybe for basic understanding, one level of testing is done, but regularly cannot be done. So if you look at the brain, if there's a blood-brain barrier, we don't have a blood-brain barrier like a diaphragm. So it is not very clear cut. So that is why if the disruption of the blood-brain barrier occurs, the liver enzymes, liver markers also can be seen in CSF, and the blood-brain barrier is disrupted. The CSF in the brain representation of this biomarkers can be seen in the serum. So this is an easy way of collecting the sample, simple blood test, and getting this done, all this test within a span of time. But presently it is not available. It is actually called proteomics. So the proteomic study is study of the protein, and these proteins which they have will have the biofluid based content of this is been analyzed. So looking at a neuron, axon, myelin sheath, and myelin basic protein, and this is a axon specific tau, that's what is specific of where we have an augmentation of this cell, and glial cells of what we have from the astroglia. And if you have a, so this is how it is there, neurofilament, whether we have a L means light and H means heavy. So, and again, ubiquitin, and the metabolites of this. And these are the things which can be, if the hypothalamus is there, you can look at the copeptin, so ghrelin. So these are things a lot of have been studied, but specifically which area has been damaged more can be identified by looking at these biomarkers. Next. So what are the classes? You have immune markers and markers of inflammation, and we all know from very COVID level of IL-6, every Tom, Dick, and Harry will know what it is. And the hormones, which actually seen the copeptin and nespatin, and coagulation and vasculature, things like thrombospondin 1 and vascular adhesion protein 1. And protein markers are, this is called specific 100B. So the protein marker which is there, and GFAP means that means glial fibrillary acidic protein, and this is what is a tau. The tau is nothing but intracellular and micro tubule associated protein. So this is a neuron specific enolase. So this is actually marker. The one thing is, I'll tell you the importance of this, and this is NF means neurofilament L and H, and ubiquitin's terminal C. So this is a lactate dehydrogenase which hydrolyzes to L1. So these are the classes we have. Next slide, sir. So these are, when it's there, the origin of this protein biomarker comes from these areas. So this is a full form of it. What is there? Like phosphorylated tau protein or microtubule associated. And whereas this is a specific protein of 100B, which has been studied. Particularly in Hyderabad, few centers are doing S100B and NSC regularly, and neuro centers. And I actually, when I was preparing for this study, I actually found out from the Rivera lab as well as a Bombay lab and other labs to understand how important, how much cost it is happening. But what Dr. Samvedam told me that they are doing, it is costing only, one is 1,500, one is 3,000. So rest of things I need to find out further. So these are things which actually, it is being evidenced and proven that a long back, it is been heavily coming into the CSF from the CSF to the serum in a severe traumatic brain injury, and moderate severe, it is representing. The only thing is how to represent and understand the mild TBI to this, and without going for the invasive procedures. Next. So we'll come to the one by one. What is glial fibrillary acidic protein? It is actually astrocyte specific. So it is an intermediate filament protein, And actually it is actually, you know, the protein representation, the marker of astrocyte activation. So it has 8 isoforms and it is a subtypes actually it is called, and it is actually seen with the breakdown products. So there's something called track 2B study, TRACK TBI study was there, which cohort study, and they have studied and said that it is being raised specifically in the traumatic brain injury, even the mild injury or this one. What is important here is that normally we look at the patient and say, okay, patient is fine with discharge. But when the GCS is less than 12, please remember this, if the Glasgow Coma scale is less than 12 and this GFAP is present abundantly, that means he is going to die in 6 months, maximum number of people. That has been studied. The outcome based, this is a study of biomarker. If this biomarker is there, if the TBI is present with the GCS less than 12, and the unfavorable outcomes has been seen after 6 months. So this is one of the important evidence where we can see, and it is increased, it is correlated with the abnormal CT scan in the mild TBI. So that's why whenever there is a GFPI is there, even the GCS is only 12, better to go for doing this. Another important point to understand is the combination is always important. We know that we correlate and combine. We cannot just treat only the investigations. We have to see clinically. Next slide. So,
sir, can I ask sir one question?
Yeah, please.
Sir, this now we, as you mentioned that the GCS of 12, we know that it is less than 12 is a poor prognosis only. Then how will exactly this will correlate, sir?
So, like for example, there is the new ELISA technique for GFPA breakdown products has been detected in the both mild and moderate TBI. When you are doing normally the GCS less than 12 is a moderate. So here the mild is above 12. Here there is no structural damage in the brain, and there is no bleeding or anything is there like diffuse axonal injury. At that time, if the GFPA is very high, so that means the mortality is very high. If that GFPA is less, that means blood-brain barrier is not damaged much, so your chance of survival is more.
Okay, sir. Thank you, sir.
Did you get the point, Srinivas? Am I right?
Yes, sir.
Yeah. Go to the previous slide, David. Yeah, this is ubiquitin C hydrolase L1. So this is actually ubiquitinating enzyme. So it actually, this is expression of the neuronal cells mainly, and it is highly brain specific, and only it is present if there is a blood-brain barrier dysfunction is happened, and there is increased dysfunction of this. It is also studied in many patients. With respect to the sensitivity specificity, it is not, still requires further education and studies because it's not fully specific. And here it is because levels is increased only if the blood-brain barrier is damaged. Otherwise, it is not going to see in the serum. So that is another way of looking at it. The combination of UCHL1 and the GFPA are going to give us a very good diagnostic utility. That has been clearly mentioned. Next. So this is an intracellular microtubule associated protein, and it is particularly very enriched in axons. Okay, and they have almost 48. I mean, they say kilodaltons. No, the weight of this is around 48 to 62, and it associated with the disruption of the blood-brain barrier again, as I told you from the beginning. So it actually, there is something called, you look at a tau and CETA. The both actually studied, but it's not regularly doing it. But they have studied in a research methodology, and if the ratio of this is been high, that means the outcomes are poor. So they'll predict the severity and outcome in the, actually it is more present in the severe TBI, but in the mild cases, they look at how it is going to be useful. That is because recently there is a development of ultra-sensitive SF platforms, which can enable us to identify this. Previously, the testing method was not there. So that's where the entire difference has come. So you have to really look into the pathophysiology of this from the top with serum and acute phase of TBI with the various levels of TBI severity can be identified. Next. I'll come to the neuron specific analysis. It is, as I told you, even though it is one of the best easy method of looking at presently, many people are doing it. At the same time, it is not specific because it is abundantly present in the RBCs. So there can be false positivity there. That is the reason whenever we do neuron specific analysis, better to do combination of the axonal injury looking at the phosphorylated neurofilament H. Because neurofilament H and neurofilament L, that is, it depends on their weight. So the kilodaltons, which is around one is 90, one is 115. So with this, if you have a combination of neuron specific enolase and neurofilament H, that means it's very clear. And very important thing, if you remember this point, acute TBI levels of outcome. The problem is in injury, particularly in the children, it has been studied less than 4 years of child abuse. Because for child abuse, the visible markers are not seen. But if there's an injury of the brain like compression or hitting or concussion anything, you can see this enzymes, neuron specific enolase, and which is actually should be monitored after 72 hours. That means third day, because immediately doing is not much useful. Doing it diffusively after levels increase to 72 hours, which has an unfavorable outcome, or diagnose it as child abuse. That means you come to the jails or small hostels, wardens, in it has been studied, particularly less than 4 years, very specific and useful when you have a combination of this. Next. So this is what specific 100B protein, which is actually intracellular calcium binding protein, and which is actually which has actually breakdown products as well, and which uses more than 12 hours post-injury values are reliable compared to the immediate, and it actually gives the outcome marker. It's called, it's an outcome marker. So here it is a Glial specific calcium binding protein, as I told you, and it is also can be seen in urine also, because if you look at the urine levels correlate with the serum levels, that means you have to know the prognostication is better, and it should be measured after 24 hours is better. So there's something called Glasgow outcome scale. So that means Glasgow outcome scale, if there's a score is less than 4, or death at 3 months after injury in severe patients is being identified. So it is there that the elevation has been found to be after mild TBI. It may not be very correlating with the severe TBI. Next. So we all know like cardiac markers, when you're looking at, we have this diagram already, we know that when CKMB is to be raised and when this protein is raised, when how long it is going to stay. So like that same way, after a traumatic brain injury, this is 0 to 120 hours and this is weeks to months, because it's going to stay for months together. So this is the difference how they have actually studied in 2016 itself. Next. See, this is what as a diagnosis and biomarker of combination, and where, like, we all know that IL-10 is not very specific. It is seen in the inspection, inflammation, and as well as it is the specificity is different from the sensitivity, because it may be 100% specificity, but only it was 27% sensitivity. And if you look at the specific serum 100 binding protein, whose sensitivity was only 18% at the same patients. So it is not correlating with that. But whereas when it comes to this is actually whose specific was 6%, but it's been more specificity is there, less sensitivity. And the combination of these enzymes, because a sample study of these all studies, multiple studies have looked into that, and with the serum metabolomics studies, and they looked into the what is at the time of admission blood drawn and specificity is being measured. So these have given a combination, has given a high sensitivity and specificity. Look at it. Look at this combination of these enzymes, even if it's more than GCS 14. That means 14 and 15 GCS is important here. The note this point very importantly, that the GCS is normal, and you look at the sample, this specificity sensitivity is very, very high. So this is what is a very good important point. Next. So these are called prognostic markers, and this is the specificity and sensitivity, what I've told you. And we need to have further data in future to have a more reliable point of care, bedside, reproducible, and correlating with the clinical. Thank you. Next. Next, David. Yeah. Oh, no, sorry, before. Yeah. So, as I told you that the combination approach is important. And in the combination approach, when you look at this specific biomarkers, and along with this, look at the GCS, and you can able to identify the each has been given differently, which is where, which biomarker is were in focal lesions. You go for this combination versus diffuse axonal injury, and if it is for predicting the outcome, go for tau and p-tau ratio. And if it is for diagnosis and prognosis, go for, as I told you, GFP and UCHL1. So these are the important aspects where we can look at the methodology of this one. Actually, there's something called neurofilament and neuroaxon products, which actually gives distinguishing between the focal and it's written here, no? Yeah, whether it's a focal or this difference, it actually gives by the degradation products. That's called alpha 2. It is not written here. Alpha 2 spectrin, which has its degradation, that's called SBDP. So that is can be measured, which whether it's a focal or it's a entire diffuse area. Like for example, it is a maximum area has been come. Next. Whenever the traumatic brain injury patient comes, so we look at the GCS, and if its GCS is very high, we know it is severe. Anyway, it goes to NICU, and you look at the samples, and only it actually analyzes and shows the severity. But when it comes to the mild, it is to be more understanding. Next. One thing which I have not mentioned, which I would like to tell here, is that there are a lot of studies understanding about the neurospecific enolase, and particularly for a post-cardiac arrest patients to confirm the patient's severity of brain death confirmation. So actually, it is said that if this is going to be high, and they studied when there was a 33 degrees, 36 degrees centigrade temperature when they did TTM. At the time of TTM study of all these patients, they collected the sample, kept the sample into the out. I mean, they studied for out of hospital cardiac arrest and in hospital cardiac arrest patients. These samples were collected and kept it minus 80 degrees centigrade for storage, and they did it after 6 months. There is a flaw in this study for the particularly for the engine, but whereas that study is not flawed for this, because the severity of the case and the matching of the patients after 6 months of doing it, there is a little bit of difficulty. So because the study and the methodology of laboratory is not available at the bedside or to that same hospital, that is the reason they studied, and they understood that the combining neuron specific enolase and initial neurological examination improved the prediction of the neurological outcome. So it is being, they looked at the outcome of those patients and coming to the conclusion. Next. So this is another thing, neuron specific enolase as a predictor of death or a poor neurological outcome out of hospital cardiac arrest, which as I told you, presently we all know there is a lot of debate going on. There is no difference between 33 degrees to 36 degrees centigrade, but still they collect the samples from first day, second day, and third day, and that is what they analyzed and looked into the case of this one. Next. So when you look at these studies, there's a false positivity rate is not very high, but whereas the similarity between the study looked into the what is received, I mean, and if you see ROC, and there is no much difference of this what I have mentioned in this. So they predicts the outcome in comatose out of hospital cardiac arrest. Next. The conclusion of this talk is any current single outcome measures may not be useful clinically. The serial timed measurement of candidate biomarkers is necessary, and biomarkers can add value to composite prognostic tools. Complex interplay of proteomics, system biology, and bioinformatics. A lot more studies needed before establishing clinically useful decision-making tools. But one thing I would like to tell you is that, particularly for a child abuse, mild TBI, where even particularly like in nursing homes, you don't have a CT scan, you don't have this, and whether to send for CT scan, required, not required, and prognosticate. If it comes FDA approved point of care monitors, is going to be boom, and importance makes a lot of sense. So thank you very much. David?
Sir. Thank you, sir, for a nice presentation.
Next.
Next, sir.
Okay, na?
Thank you, sir. Mohan, sir.
Cheppan, sir. Chepsinu.
Sir, this one, now a patient who has a cardiac arrest, and just scenarios.
Yeah, please, please.
Let's discuss few things. And where to do? Because if I have a STEMI, పక్కా STEMI ఉందనుకోండి, నేను డ్రాప్ టీ చేస్తే పెద్దగా అంత వాల్యూ ఉండదు దానికి, ఈవెన్ దో ప్రోగ్నోస్టిక్ మార్కర్ ఉన్నాడు. అట్లానే ఇఫ్ ఐ హ్యావ్ ఎ GCS ఆఫ్ patient who has a cardiac arrest, and something like we are doing some procedure or something we have done, and patient has a cardiac arrest, and after 48 hours his GCS is only 3 to 5 on a ventilator. So one type is that patient. Another type is a mild head injury, that is around 12 to 15 GCS. So mild head injury patient who has a little GCS of 12 to 15, this patient. And some patients will have a diffuse axonal injury where we may not identify anything, but GCS is poor, like moderate to severe. So which type of scenarios this helps us? Because the cost is very high.
No, it is not. The main issue is that, Srinivas, cost is not high.
Sir.
I told you, mentioned in the beginning itself, the cost presently in our hospital, of some hospital CT scan, those things are going to be 6,000 to 15,000, whereas this is going to be 1,500 to 3,000.
Okay, sir. But should we do it repeatedly for prognostication, or once is enough, or after how many days this enzyme is eliminated?
If you see that level of the diagram or graph which I have given, sir, which specific enzyme you are doing, because as you said, all the things is combination is important, and doing a combination and looking at the duration. For example, if you are doing the NSC, it should be after 72 hours. If you are doing the other marker, it should be early, because in the day one itself, within 12 hours you should do. When the patient comes after the injury, GCS is normal 13 to 15, then go for these two enzymes to make whether he requires CT scan or further monitoring or further admission. For example, patient comes to your hospital, mild TBI, I'm not talking about severe TBI. Severe TBI, we all know it's already there. It's only evident, it's already present. We are only worried about a mild TBI to understand whether he requires admission, whether he requires further investigation, or how to prognosticate. That is what these biomarkers at this point of time are getting more useful.
So severe, there is no major useful.
There is no major useful severe except for a, like for example, confirmation of the brain death. You don't have a DSA. Like for example, in our hospital we have a DSA, but every hospital may not have DSA. Presently, our Jivandan is acceptable with only the reflexes. But if you do these enzymes, it is more specific.
But DSA also
DSA also లేదు, but this DSA is 100% guarantee foolproof కదా.
But అది అంటే 100% fool proof అయినా కానీ if we don't have contraindications to examine clinically, I think clinically will go good కదా సార్ brain death criteria.
వినపడలేదు, సరే చెప్పండి
సార్. ఇప్పుడు మనకి కాంట్రాఇండికేషన్స్ ఏం లేవు అనుకోండి బ్రెయిన్ డెత్ ఎగ్జామినేషన్ కి, అంటే లైక్ హైపర్ నాట్రీమియా కానీ, హైపోటెన్షన్ కానీ, హైపాక్సీ కానీ లేకపోతే, then we can go with clinical criteria whatever is given by the Jivandan committee, and we can declare no need of a DSA. So I think
in case of any litigation, somebody wants the evidence,
and
only
yes sir.
Otherwise,
yes sir, I agree. If the patient is a litigant, definitely we need to do it.
Patient relatives,
yes sir. Sorry
sir, you said the mild TBI, and if there is a combination of what is that NSC and another one,
UCHL1,
both are elevated. It increase the mortality or increase the only neurological, worsen the neurological outcome? How it is affect the mortality?
Increase the mortality after 6 months, because the process of degeneration, inflammation, apoptosis, those things are going to be stays from weeks to months.
So it affects the other systems and increase the mortality.
No, it doesn't affect other systems. It affects only the brain.
How it affect the mortality then?
That is what the study is. That's called track TBI cohort study.
Sir,
Sir,
how
sir,
it
if
will affect the
if
depth
the
of the
patient
patient?
doesn't improve neurologically, automatically his length of stay increases, he requires tracheostomy, he requires then automatically some.
Alaga sir, alaga, simple. There is some people who are staying more than few years with the tracheostomy. Am I right?
Yes, sir.
So
Yes.
if these two are high, and then that means he's going to die faster than them.
Yeah,
That means inside the damage is going to be still further. It is not stopped. Like severity score, like for example, we know, like for example, I'll just tell you, I may not be giving correct example. Like you have a heart failure, you have a pro BNP of 10,000, or what is going to be mortality? And if the it's going to be only 500, what is going to be the mortality? Still heart failure may be the same. And presently new concept is coming with the normal LV dysfunction heart failure. So like that, the brain is damaged and is going to get damaged further if these are present in abundance.
yeah, heart failure with preserved LV function.
అది పర్లేదు మొన్న ఏదో కాన్ఫరెన్స్ లో విని గుర్తుపెట్టుకోండి అంతే.
Okay, sir.
Sir, what about maybe it may be useful in moderate TBI, sir, because here the moderate TBI patient may improve or may not improve. Can we have a clinical idea by doing these enzymes also?
Maybe I need to read more.
Because endukante severe we know that prognosis is worse. Mild definitely this will help. Moderate is the area, the gray area we need to understand more better. This may help, sir.
Maybe I need to further study. My study is not sufficient to answer that.
Any questions? Mohan Rao garu? I think Akshit read on this biomarkers, brain biomarkers.
Akshit, yeah, Akshit, చెప్పండి.
గుడ్ మార్నింగ్ సార్. ఏం చెప్పడానికి ఏం లేదు సార్.
అలా కాదు, you can add on things.
You read and you collected so many biomarkers, no? Papers.
Because when you read more, you have more information. So please share with everybody.
సార్ యాక్చువల్లీ మీరు అన్ని పాయింట్స్ కవర్ చేస్తారు సార్, నాకు తెలిసిన. ఇంకైనా అడిషనల్ గా ఉంటే ఐ విల్ పుట్ ఇన్ ద గ్రూప్ సార్.
సార్ ఇది సార్ గుడ్ మార్నింగ్ సార్ మోహన్ సార్.
గుడ్ మార్నింగ్ మోహన్ రావు
సార్. ఈ టాపిక్ ని మనం ఏమైనా అంటే ఎక్స్పాండ్ చేయొచ్చు అంటే ఓన్లీ ఇట్ ఈస్ టీబీఐ వరకే వచ్చింది
అలా కాదు.
లైక్ దట్ డే యు అంటే మీన్స్ ఇన్ఫెక్షన్స్.
Mohan Rao, if you remember, we give the same class in our this one. Satya Rao neurologist came and told we have a disease specific biomarkers.
Yes.
So every disease, every neurological disease, we have a different biomarkers, because it's a very clear evidence of my third slide saying which axon, which neuron, which is giving biomarker. So same way, we have a biomarkers like you have a prostate specific antigen PSA. So it's for PSA present. Like
particular
cancer.
Yes. For say other neurological disorders like meningitis, meningoencephalitis, Japanese encephalitis, so many particularly CNS involvement cases, whether in intensive care units, whether those things are useful or not, we have to check it, sir. Because always we will do CT, MRI and LPs for things. Sometimes LP gives the proper reports, but in sometimes maybe wrong reports also, no, sir. That time maybe this we have to, whether is there or not, I don't know.
Sir, are there any specific biomarker like if you check the CSF analysis, you know that the proteins are elevated and polymorphs are increased, then you know that it is a bacterial meningitis, but we don't know which bacteria. So we have to give a even though you know that bacterial meningitis, we have to give antibiotic which will cover all the bacteria. Is there any specific biomarker that shows that this is the specific bacteria causing the meningitis?
Specific biomarker to find out what?
Particular bacteria.
So particular bacteria we have to do PCR only,
virus.
sir.
డైరెక్ట్ గా అది పిసిఆర్ పంపిస్తే సరిపోతుంది కదా.
Panel of bacteria infected organs.
Are already existing, but is there any specific biomarker, brain biomarker, to identify this also? Not looking at the PCR or culture sensitivity only. Are there any available?
I don't think so, sir.
మీరు అడిగారు కదా, అందుకని నేను అడుగుతున్నాను.
అంటే పర్టికులర్ ఆర్గానిజం గురించి ఉండకపోవచ్చు. We can rule out for meningitis, TB. Like actually autoimmune meningitis, autoimmune meningoencephalitis, they will do NMO antibodies, the CSF.
Sir, Mohan Rao sir, when there is already a panel which can examine and tell the antibody organisms, why we need to worry about the enzymes, sir? So
yes, sir.
Any area la develop chestha better kada.
Yes, yes.
This is all functional things. Sir, నాకు ఒక రిక్వెస్ట్ సార్. మోహన్ సార్
చెప్పండి.
మోహన్ సార్, ఇది అంటే నథింగ్ టు డూ విత్ దిస్ క్లాస్. నాకేమనిపిస్తుంది అంటే, జస్ట్ ఇట్స్ మై స్మాల్ సజెషన్ ఈస్, suppose we are having a class but none of them has an extremely good experience on the neurocritical care where we do these enzymes and all these things. So NIMHANS is the best thing to do. So with your contacts, when we have a class, can you invite some person so that he can give during our discussion? We can have a half.
That is the reason last time some radiologist, somebody has been involved, so they can give inputs.
Yes, sir. సో ఇట్లా ఇన్వాల్వ్ చేయొచ్చు ఎవ్రీ వీక్.
హ్యాపీగా చేయడం బెటర్ కదా.
ఎవ్రీ వీక్ కాకపోయినా కొన్ని స్పెసిఫిక్ క్లాసెస్ ఎవ్రీ వీక్
మంత్ కి ఒకటి
దిస్ టైప్ ఆఫ్ స్పెసిఫిక్ క్లాసెస్.
అంటే హూ ఇస్ రియల్లీ గుడ్ ఇన్ దేర్ ఏరియా చేసుకుంటే బెటర్.
ప్రాక్టికల్లీ దే విల్ టెల్ వాట్ దే ఆర్ డూయింగ్.
yes sir. ఈవెన్ మీకు అంటే ఇంటర్నేషనల్ స్పీకర్స్ ఎవరైనా తెలిసినా గానీ మీకు కనెక్షన్స్ ఉంటాయి కాబట్టి వాళ్ళనైనా కానీ ఆన్లైన్ తీసుకురావచ్చు.
అవునవును. ఓకే శ్రీనాథ్, ఫస్ట్ వీ హావ్ టు సెలెక్ట్ ద టాపిక్.
ఎస్, 1 week ముందు చెప్పాలి టాపిక్.
యాక్చువల్లీ
మాత్రం చెప్పకూడదు.
ఎన్సీనాస్ ఉన్నాడా, మన మౌనంగా ఉన్నాడా?
మార్నింగ్ సార్, అదే డౌట్ అడగాలి.
చెప్పు సీను.
సార్ ఏం లేదు, ఇప్పుడు మీరు మైల్డ్ టీబీఏలో అడ్మిషన్ కావాలా లేదా అని డిఫరెన్షియేట్ చేయడానికి బయోమార్కర్స్ కావాలి అన్నారు. అండ్ దేర్ ఇస్
ఓన్లీ వన్ రీజన్, నాట్ ఫర్ ఎంటైర్ రీజన్.
వన్ రీజన్ అంటే అడ్మిషన్ కి క్రైటీరియా తీసుకోవాలా వద్దా అనేది ఒక రీజన్. సెకండ్ స్టేట్మెంట్ ఈస్ ఇట్ ఈస్ గోయింగ్ టు గివ్ 6 months మోర్టాలిటీ. సో రెండు స్టేట్మెంట్స్ అటు ఇటు అవుతున్నాయేమో అని
నేను ఏం చెప్తున్నానంటే, చిన్న డిఫరెన్స్ చూడండి. ఇఫ్ ద జీసస్ ఈజ్ లెస్ దాన్ 12, then automatically he needs admission. For that patient, the prognostication value is going to be combination of the GFP and UCH. But for the patient whose GCS is 13 to 15, who doesn't want to get admitted, for him is admission. This is the 2 points difference. Am I clear, Srinivas?
ఓకే సార్. అంటే ఇప్పుడు 13 to 15 ఉంది, ఇఫ్ దేర్ ఈస్ నో లీజన్ ఇన్ ద బ్రెయిన్ అంటే సిటీలో
అసలు వద్దు, సిటీ చేయాల్సిన అవసరం లేదంటున్నా కదా నేను. ఏంటంటే నార్మల్ 15 ఉంది అనుకోండి, 14-15 ఉంది జీసీఎస్, వాడికి ఎందుకు సిటీ చేయాలని క్వశ్చన్ ఉంటుంది కదా వాడికి. వై షుడ్ ఐ గెట్ ఎ సిటీ స్కాన్ డన్? బికాజ్ లాట్ ఆఫ్ రీజన్స్ ఇచ్చాను. కాస్ట్రోఫోబియా, డిస్టెన్స్, కాస్ట్.
సార్ ట్రామాటిక్ బ్రెయిన్ ఇంజురీలో if you don't do a CT with a GCS of 13, there is a problem.
Legally
let it be 14-15, Srinivas.
అయినా కానీ సార్ ట్రామాటిక్ బ్రెయిన్ ఇంజురీలో
mild TBI గాని it should be CT has to be done, sir.
Because suppose this patient might have a EDH or SDH where his GCS is at present okay, he may suddenly cone later after some time. So CT scan అయితే కొంచెం అంటే మ్యాండేటరీ అనిపిస్తుంది నాకైతే.
అంటే మెయిన్ ఒక పాయింట్ ఉంది ఇద్దరు శ్రీనివాసులు ఇక్కడ మెయిన్ దీంట్లో ఏంటంటే మైల్డ్ టీబీఐ నుండి విచ్ ఆర్ డిఫికల్ట్ టు డూ, ఫర్ ఎగ్జాంపుల్ చిల్డ్రన్ ఆర్ పీపుల్ హు ఆర్ claustrophobic who don't want to do those kind of things, you can get the things that the damage is not there. Like for example, mild damage also you'll be able to identify with this because it's more specific sensitivity vaste. This is going to be more informative to go for CT scan. Otherwise not required in the point kuda undi ikkada dintlo adi maybe important ikkada.
Okay.
Are we legally right?
అంటే శ్రీనివాస్ గారు మోస్ట్లీ ఏంటంటే
Can I give an example? One incident happened. One patient came with history of trauma with fractured femur. Okay, he advised CT scan at the time of admission, even though the GCS was 15/15, because of history of trauma, polytrauma, and there is small abrasion on the head. So he was posted for surgery after 48 hours. Just before posted in PAC, again anesthesiologist asked for CT scan brain, and there was a argument between the orthopedic surgeon and the anesthesiologist that why you advised CT scan and GCS 15/15. Okay, later if you take the proper history of the presentation, then why he asked this one? Patient had a history of loss of consciousness for few minutes, and patient had the history of for few minutes and vomiting once or twice, but patient could not give the information. There was no relative witnessed relative. Then okay, after argument all these things, finally they decided, then he said I will not give anesthesia without CT scan. Then CT scan was done, there is a hematoma, a small subdural hematoma. So how can you justify, even though it's a polytrauma and GCS is normal, so these incidents are happening. Is it mandatory to do CT scan with normal GCS, or every polytrauma patient needs CT scan?
So GCS is not only the indication. GCS is not only the indication. There are indications when there is a history of LOC, there is a history of vomiting, there is a history of ear bleed, and the mechanism of injury, and all these things. When you consider all those things and the facial injuries, so in those conditions also, even if your GCS is 15/15, you have to go for a CT.
సార్ ఇది నాకు ఈ ఇండికేషన్ ఈ బయోమార్కర్స్ యూజువల్లీ యూకేలో యుఎస్ లో ఎందుకు పెడతారంటే, నాట్ ఓన్లీ దీస్ ఇండికేషన్స్, బేసికలీ ది అవైలబిలిటీ ఆఫ్ సిటీ స్కాన్ అండ్ ఎంఆర్ఐ ఈస్ డిఫికల్ట్ ఫర్ దెమ్ యాక్సెసిబిలిటీ, బికాస్ వాళ్ళు గవర్నమెంట్ ది కాబట్టి. సో ఐ థింక్ దట్స్ రీజన్ వై దే కమ్ అప్ విత్ దిస్ టైప్ ఆఫ్ ఎంజైమ్స్. మనకంటే ఎప్పుడంటే అప్పుడు ఉంటాయి అనుకుంటున్నాను నేను.
Correct, sir. One valid point, as Mohan sir said, in mild TBI to prognosticate it may be required.
Yes sir, definitely prognostication is required, that one.
Yes. ఏమన్నా ఉన్నాయా?
అక్షిత్ యాడ్ చేయలేదు,
మర్చిపోయి అంటాడు సార్, చాలా రోజులు అవుతుంది.
అది యాక్చువల్లీ నేను 6 months బ్యాక్ ఒకసారి ప్రిపేర్ అయ్యాను సార్. యాక్చువల్లీ
ఇంకెవరైనా, రాణి మేడం, రమణ్ ప్రసాద్ గారు, సీనియర్స్ ఎనీబడి, అనురాధ?
హలో.
ఎస్ మేడం, చెప్పండి.
సార్ కొన్నిసార్లు న్యూరో సర్జన్స్ దే సే there's no problem అంటారు. పేషెంట్స్ విల్ గో ఆఫ్టర్ us, they say no problem, but why he's not improving, why he's not normally at అలా అడుగుతుంటారు కదా. Is there a role to do any of these in that situation? Will it show us and which one is better to do, which marker?
అందులో రాసి చూడండి మేడం, లాస్ట్ స్లైడ్ లో ఇట్స్ కాంబినేషన్ ఆఫ్ బోత్ ubiquitin C and neurofilament, and if it is particularly tau and C-tau.
సార్ వినిపిలో
వినపడుతుందా మేడం?
ఇప్పుడు వినిపిస్తుంది.
ఇప్పుడు మనకు 4 ఎంజైమ్స్ ఇక్కడ మెయిన్ ఇంపార్టెంట్ మేడం. ఒకటి న్యూరోస్పెసిఫిక్ ఎనలైజ్ అండ్ S100B, న్యూరోఫిలమెంట్ అండ్ గ్లైల్ ప్రోటీన్. ఈ 4 చేస్తే అందులో మనకు లోకల్ డిఫ్యూజర్ తెలుస్తుంది. అండ్ యాక్చువల్గా లాస్ట్ స్లైడ్ డేవిడ్ ఒక్క లాస్ట్ స్లైడ్ కాంబినేషన్ చూసావా? Last slide, sir. Just before that, before studies. Yeah, conclusion. దానికంటే ఇంకా ముందు. వెళ్ళండి సార్. ఓపెన్ చేయండి సార్ తొందరగా, టైం అయిపోయింది కదా. కొంచెం ముందుకెళ్ళండి సార్ డేవిడ్ గారు, అయిపోయింది. కాదు సార్, లాస్ట్ 4th స్లైడ్ అందు కాంబినేషన్ స్టడీ అని ఉంది కదా సార్. సరే నేను చెప్తానండి ఇందులో చూసి. ఇదిగోండి మేడం,
చెప్పండి.
if it is a acute plasma p-tau levels and the ratio of this one, which actually this one prevents, and GFPA and UHC1. సో ఈ రెండు చూస్తే మనకు ఫోకల్ ఆర్ డిఫ్యూజర్ తెలుస్తుంది. దాన్ని బట్టి మనం we can assess and we can say that madam, these two.
Okay, so at that level like can we do that and show them that he still has the problem and
నేను మొట్టమొదటి అదే కదా మేడం సెంటెన్స్ కూడా అన్నాను. సజెస్ట్ వచ్చి నథింగ్ టు డూ అన్న వెంటనే దే ఫీల్ ఇట్స్ ఓకే ఫైన్, దిస్ ఇస్ గోయింగ్ టు గివ్ us ఎవిడెన్స్ అంతే.
రివర్ చేస్తున్నారన్నారా ఇవి?
రివరా కాదు మేడం, మామూలుగా ఇట్స్ ఓన్లీ రొటీన్ గా హైదరాబాద్ లో చేస్తున్నారు. వీఆర్ ప్లానింగ్ టు డూ, ఇక్కడ కూడా ప్లాన్ చేస్తున్నాం అట్లీస్ట్, ఎందుకంటే కాస్ట్ ఈజ్ ఓన్లీ 3,015 అన్నారు, అందుకోసం.
ఓకే ఓకే
డేవిడ్ ఉన్నా అయిపోయిందా? డేవిడ్, హలో డేవిడ్
గారు
ఇదేనా?
అయిపోయిందా? వెళ్ళిపోవచ్చా? క్లాస్ అయిపోయిందా? చెప్పేశాను.
చెప్పారు సార్.
చెప్పాను సార్.
ఓకే సార్, there are no doubts and thank you sir for